Yeah, hi, good morning, everyone. Today's session is on cardiac pacemakers. I know it's written as temporary pacemakers, but I'll try and give a quick overview of cardiac pacemakers in general and cover temporary pacemakers in a little more detail. So, the layout of today's talk will have an introduction to pacemakers in general and how they work, and some basic stuff about pacemakers and indications, later pacemaker coding, and then we'll go to temporary pacemaker basics and just touch upon transcutaneous pacing, and lastly troubleshooting and complications, and a couple of slides on newer devices. So the history of it actually started in 1950s, and the first one which was ever designed used about 23 pulse generators, and also had something like a 5 electrode system. And from there it progressed to what it is today over a period of time. But as you can see, until the late second decade of this century, there wasn't a lot of development in terms of the size of the pacemakers, or the size of the pulse generator, or the mechanisms in which fundamental mechanism in which pacemakers work. There was a lot of development in the way the software was designed, the algorithms were designed. Pacemakers became a lot more safe. Things like runaway pacemakers and all that stopped happening in the 2000s. And so somewhere, I think it's 1998 was 1997 or 1998 was the last series of the pacemakers which were made, which were prone to these kind of uh, serious adverse effects which were related to the pacemakers directly. And recently, of course, FDA has approved even something called a leadless pacemaker, which has some specific areas where it can be used. And in the future, there are even pacemakers which may not even need a battery. So, exciting times ahead in the pacemaker world per se. Types of pacemakers, there are various ways of classifying it: temporary and permanent, based on chambers, single chamber, dual chamber, or dual chamber is also called the AV sequential. And the most recent one, of course, the biventricular pacing. And programmable, non-programmable. Based on lead systems, you have the transvenous systems that most of you are familiar with. Then you have the bundle of His pacing, which is basically developed to kind of prevent harmful effects of the right ventricular pacing. And in this particular method, the area where the leads is fixed is the bundle of His. And this is basically supposed to theoretically reduce the odds that dysynchrony will occur when there is RV pacing going on. And then there is left bundle pacing, which also is pretty much the same. It aims to achieve the same as bundle of His pacing. Then epicardial systems. This is routinely used during cardiac surgery. And then, of course, the leadless systems. Just a very small note on cardiac anatomy. I know most of you are very well aware of it, but some of these slides which are going to come further have a direct a relationship to these things which are going to be said. You have the P wave, which basically generates, which is representative of the atrial repolarization. Then you have the AV node, which represents the PR interval, where the AV nodal delay occurs. And each one of these, for example, is kind of programmable in the modern pacemakers, which are available nowadays in various ways. And then the impulses pass through the bundle of His, and then the Purkinje fibers, which are rather the fastest. And it is these last two places which kind of form the basis for biventricular pacing, for example. And this whole ventricular depolarization forms the QRS complex, and the repolarization, of course, the P wave. As you can see, uh, this is essentially where most pacemakers, except for biventricular, Almost all of them are the lead is placed in the apex of the right ventricle, or on occasion when we need a specific bundle of his type pacing, it is uh, placed around the bundle of his, which is again close to the RV apex. Or when you want a pacing which is, like I said, the left bundle pacing, it's kept close to the septum. So uh, where you place the leads based on fluoroscopy for permanent pacemakers depends on this cardiac anatomy as well. And there is a specific modality called biventricular pacing, where the third lead is placed at the coronary sinus, which in turn paces the left ventricle. So, most of you know there is a component called a pulse generator. In a temporary pacemaker, the pulse generator lies outside the body. In a permanent pacemaker, it lies inside the body, on top of just below the pectorals. Leads again single chamber, dual chamber, or biventricular. You can see there is an RA lead, there is a RV lead, and the coronary sinus lead only for biventricular pacing. And leadless pacemakers are also available these days. Indications, I'll not go through this in detail, just a quick summary of it. Class 1 is the indications for which a pacemaker insertion is definitely beneficial, and there is evidence, robust evidence, that it alters mortality in a very direct sense. So you have symptomatic sinus bradycardia. Well, this is usually reflective of a heart rate below 40, and a symptomatic chronotropic response basically means the exercise induced needs of the heart rate are not met by the heart. The complete heart block and advanced second degree heart block, Morbid's type 2, symptomatic Morbid's type 1, which is important to remember. So I'll again not go into the details of the ECGs of this. That's uh, uh, for another time, perhaps. And exercise induced second or third degree heart block. And class 2, a lot of us have actually seen pacemakers being inserted for many class 2 indications. It's not entirely wrong. There's just a little bit of conflicting opinion, because there is a lack of large randomized control studies, or even small randomized control studies, very clearly saying that it may be beneficial. So these are sinus bradycardia without there are symptoms and there is bradycardia, but there is no association between the sinus bradycardia or and the symptoms. For example, a sick sinus syndrome, you give them a carotid massage, the heart rate drops and they faint. And at the same time, if the heart rate drops and they don't faint and they faint later, we're not sure if it is some sort of an intermittent symptomatology, or if there is an alternate explanation for it. So this would be a situation when there is no clear association between the bradycardia and the symptoms. And chronic rates of less than 40 with minimum or no symptoms. First degree heart block, when there is hemodynamic compromise, is also another class 2 indication. Bifascicular and bifascicular or trifascicular block associated with syncope. Neurally mediated syncope, this is perhaps the most controversial. Some say it's kind of criminal to do a pacemaker on somebody who has a neurally mediated syncope. Some say it's quite helpful. Opinion and evidence is kind of divided, but it's again still in the gray area. Class 3 indications have not put; those are questionable indications for which it may not be useful at all. Then there are other indications, such as congenital complete heart block, neuromuscular disorders, long QT syndrome, bradycardia-induced ventricular arrhythmias, HOCM, and heart failure. Heart failure is not an indication for temporary pacemaker. You need a specific device called a cardiac resynchronization therapy. This is actually the biventricular pacemaker I was talking about earlier. For myocardial infarction, most of you are probably aware of this. Part of it is already there in the ACLS bradycardia algorithm. If the ECG shows a second degree or a third degree AV block, then we need to kind of localize where the MI is based on ECG or angiographic findings. And if it's an anterolateral MI, then temporary pacemaker is absolutely indicated. And if it's inferior, posterior, or an unknown location, then it depends on whether the patient is stable or unstable. And if the patient is stable, we can still go ahead and uh, place transcutaneous pacemakers on transcutaneous pads on this patient, and then treat the myocardial ischemia and wait and see if the AV block resolves. Quite a lot of these patients with posterior MI, posterior wall MIs and inferior wall MIs, uh, when they are stable, we can tide over with transcutaneous pacing, and later AV block has a high chance of resolving spontaneously. And if the patient is unstable, we again see if it is nodal or infranodal. If it is nodal, then atropine works. If it doesn't work, aminophylline is something which is indicated. Dopamine also is another drug which is indicated. And if the patient remains stable, then you put in a TPI in this particular patient. The only patient where you would use a transcutaneous pace is, of course, if there is an absolute emergency and you don't have time and that's the only thing available, or if the patient is stable and has an inferior or posterior wall myocardial infarction. Uh, be that as it may, any case, if the AV block persists, then the patient needs to go in for a permanent pacemaker insertion. And this is probably an algorithm which kind of needs to be at the tip of our fingers, particularly when you're seeing a patient in the ER and has an anterolateral MI. Uh, we can do our bradycardia algorithm and all that, but if you are in a center where you have the means and the training to put in a TPI, it should go in right away. If you do not, this patient needs an urgent referral to a center where it can be done. So it's very, very important to remember this nomenclature. There are various bodies. There's a body called NAMSEC and BPG. They came together and formed a coding system called NBG, which basically defines various pacemaker modes. But for the practical purposes of this particular talk, I will just uh, stick to the old system where you just need to remember 1, 2, and 3. 4 and 5, it's uh, more of a core cardiology thing. It's used for permanent pacemakers. It's pretty much relegated to the cath lab. So the first letter, you always, you have heard of VVI and VOO and VDD and VVT and all that. So the first letter of the nomenclature basically tells you which chamber is being paced. So if it is O, that means nothing is being paced. If it is A, it's atrium. V is ventricle, and D means it's dual. 2 says which chamber is being sensed. For example, if the atria is being sensed and the pacemaker picks up a P wave being generated by the sinus node, in a case of AV block, it will pace the ventricle. So it will be A and V. Sorry, it will be V and A. And the third one is, what's the response to this sensing? So when the pacemaker senses a native heart rate, what does a pacemaker do? Does it not do anything? Then it is O. If it actually triggers uh, heart rate, triggers a cardiac impulse, then it is T. This is almost always never used, and they're very, very, very select indications in during cardiac surgery where we might use it at all, but otherwise it's never used practically in critical care context. We basically, sorry, it's not V, it's I actually. I means inhibited, and dual here has a little different connotation. It actually means either it either means triggered or sensed. It may be a little confusing for some of you, but it will get clearer as the talk goes forward. So, commonly used modes are VVI, DDD, AAI, and VVI. And typically in temporary pacemaker settings, it's almost always VVI, even though we can have dual chamber pacing in with temporary pacemakers without a fluoroscopy and a good amount of training, it's very, very difficult to place in an atrial lead. And for all practical purposes, we pretty much use the VVI mode in temporary pacemaker context, unless of course the leads are already there and the pulse generator of a permanent pacemaker is conked off and you just attached a TPI to the existing leads, then you can use AAI or DDD. Here you can see uh, the first ECG that you see one thing to remember is the chamber being paced, right? So when a chamber is being paced, you get a pacing spike. So one important thing to remember is the atrial spike is usually a very small spike, and the ventricular spike is a rather large spike. That's something for us to kind of remember. So the first one you can see it's a VOO mode. So that means the ventricle is being paced irrespective, and nothing is being sensed, irrespective of whether the patient has an atrial spike or the patient has a ventricular spike. You can see here there is a spike just before the P wave. Here there is a spike just before the QRS complex. And it has, these pacemaker spikes have no real relation to uh, the inherent cardiac rhythm. You can see the pacemaker spikes at a regular interval. So this is what we call as a VOO mode, and this is actually VVI. I'm really sorry about it, because you can see the ventricles are being paced, the ventricle is being sensed, and when there is a inherent, let me just, so one is what we call as a VVI, so which is the chamber which is being paced. So you can see there is QRS complex which follows this large spikes. So it's the ventricle which is being paced, and when there is an inherent QRS complex, the pacing rhythm is not seen. So when there is an inherent cardiac activity, it is being inhibited. So that is VVI. Here you can see what we call as a VOO mode, where irrespective of coming to the types of temporary pacemakers, there are various types, and the commonly available ones, we have the Medtronic devices, we have Philips. There are various companies which come with multiple devices, and there are a lot of confusing dials on the system, but it's like the one you see on the left side. It is a little more advanced. It has got multiple uh, settings there for your output and sensing threshold and the heart rate. On top of that, it has various modes on it. Whereas the one on the right is a little more basic, and quite often will come across devices which has only 3 settings. And for all practical purposes, uh, in the ICU, all we need to really remember is 3 modes. I mean, the 3 dials, that is the rate, the sensitivity, and the output. So I'll come to what each of those are later at the time of talking about how this is really set up, the settings of it. Uh, But just to give you a brief overview of pacemaker dials and components. So these are the 3 dials which are the most important: the rate, excuse me, the rate, the sensitivity, and the output. And I'll tell you what each one of those is in a little bit. And before moving on to how temporary pacemakers are inserted, just a small overview on the parts of it. You can see the pulse generator with the dials and all that, and then you have the 2 electrodes that you can see here, which is attached to the pulse generator. That's actually a part of the lead, and you can see all these black markings on the lead. Each of that will have a small black shade. There's 1, 2, 3, and each of that basically represents 10 centimeter each. One shade represents 10, and 2 represents 20, 3 30, and so on. And these markings are extremely important to keep an eye on when you're pushing the lead in. And on top of the lead, you can see a sleeve which attaches. One side is open, which can be freely extended on top of the pacemaker lead, and the other side is closed, rather. So this is the important part, where we need to really remember which side of the sleeve goes where, because this is a sterile sleeve, and this essentially covers your uh, pacemaker lead and prevents any antegrade infection from going in. So you mess up one side and try to screw in the wrong side into the sheath. It has happens that then you end up wasting a lot of time trying to search for a new lead, and that actually may be detrimental in an emergency. So very important to really remember which direction the sheath is sorry, the sleeve is going in, really. And then you have the sheath, which helps you basically thread the pacemaker lead in. And then of course the little syringe there, which acts as excuse me, acts as the block for the balloon. So that's in brief about the parts and dials and components. Now there's some practical aspects. I'll not go into the details of how a temporary pacemaker is really inserted. A lot of you have done it, a lot of you know it, or at least the theory of it. But just briefly, uh, before coming to the practical points in consideration, it's basically coming back to here. The jugular route is preferred, and the other route which is preferred is the left subclavian. But if you think this patient may be a candidate for a permanent pacemaker, it's better to use the right IJV, because we may need the the left subclavian for a permanent pacemaker. So it's better to kind of save that vein up and use the right IJV. And also it comes in very intuitively for everyone in the ICU to just put in a right IJ line anyway. So this comes naturally to us. Steps of insertion, pretty straightforward, standard. Most of you are aware of this. Push it in till, so that's the next slide. So point number 4, just keep a close watch on the markings. So once you have set yourself up, you have put in the sheath first, and then you have slowly pushing in the temporary pacemaker lead. Whenever possible, use a 2D echo. Uh, we all of us have done plenty of blind temp TPI insertions, not always successful. The key point here is the chances of lead dislodgement sometimes is higher if you have not confirmed the where the TPI tip is sitting, and you also need a little bit of a slack after you have hit the RV apex also, and this is quite easy to confirm with a 2D echo. If you don't have an echo, then what you do is just watch the cardiac monitor for myocardial injury pattern, where you set the monitor to V1, or that's again very important, set the cardiac monitor to V1 and watch for nest elevation as you're pushing it in. So watch the markings, push to 20 with impunity, no problem at all. And as soon as you push it to 20, slow down and push to, some say 25, some say 30. And this is the time when you inflate the balloon, which will help the pacemaker to slowly float into the RV. And then again push for another 3 to 5 centimeters and watch for the ST in V1 or a confirmation on echo. And if you hit a resistance at 15-20 centimeters, that means that RV pacing lead might be stuck in the mitral valve, no, sorry, tricuspid valve, and you might want to withdraw it and then push it again. And also, if the once you've hit the RV apex, if the tip curves on itself also, you might just keep going in without actually uh, 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 getting the resistance. Even in this case, you would want to pull it back a little and push it in again. And again, watch this sleeve direction, and it's very tempting to handle the pulse generator while you're doing the procedure. Always have an assistant to set the pulse generator, because this is unsterile. Common mistake. I've seen seasoned cardiologists doing it. This is how it looks at the RV apex on the four chamber view. You can see there is a little bit of slack there. Subcostal view is very useful to confirm the lead sitting, and quite often it's easier to visualize where exactly the lead is sitting on subcostal view as well. Once you have put the temporary pacemaker in, what do you do? How do you set the sensitivity? What is the sensitivity? It's the minimal myocardial voltage required by the electrode to sense a beat. So is the heart putting out zero point 0.4 mill? The general range is around zero point 0.4 to 10 millivolt for the atrium, and zero point 0.8 to 20 millivolt for the ventricle. So essentially, how much cardiac voltage is needed for the electrode to sense a beat is what the sensitivity is. Rate is the lower limit of rate for the device. So if the heart rate falls, in this case it's set below, one is set at 80, other one is set at 72. So if the heart rate falls below 80, then the pacemaker will kick in. And output is the amount of electricity which goes into the heart from the pacemaker. It's the amount of juice the device produces in milliamperes. How do we set it? So when we are setting up the pacemaker, you just keep reducing the sensitivity till you get a capture. So here it means if the sensitivity is higher at 10 millivolt, that means a lot of cardiac activity, or the heart needs to produce a tremendous amount of uh, electricity for the pacemaker to sense a beat. So you start with a high milliampere, and then slowly go down, go down, go down until you no longer sense a beat. And what I generally use is the rule of two, where if I sense at say 2 millivolts, I then keep the sensitivity at half, that is 1 millivolt. So at the other end, output, again you start with a lower voltage, zero point 0.4 or zero point 0.8, and then keep going up till you actually hit a cardiac activity, till you see a pacemaker spike and a capture. And usually you can set it to 2 to 3 times. The various schools of thought, some say you keep it to just above the sensing threshold. uh, I personally prefer put keeping the voltage twice for output and half for sensitivity. So that's a little counterintuitive when it comes to sensing. Sensing is half and voltage is twice, so it can get a little confusing. So important to remember it. Complications, it's again there is a big laundry list. The most common ones are infections, arrhythmias, VPCs, heart blocks, pneumothorax if you used a subclavian route, cardiac tamponade. Earlier in my slide I did mention, once you cross that 30 centimeter mark, slow down. Cardiac perforation is not as rare as you think it is, particularly in patients who have a slightly thinned out cardiac myocardium. Transcutaneous pacing, all of you have seen both these devices. It is pretty much there in every ICU. So you can see the buttons which have been laid out at the bottom. So there is something called a pacer button. So if you're putting in a transcutaneous pacing in the ER, you need to remember that it's a temporary measure. The leads are placed anterior and posterior. You need to press the pacer button and make sure you press the pacer button and confirm that the screen shows a pacer UI on it. And then you set the rate, the mode, and output, just like you would set for routine temporary pacemakers. However, since a tremendous amount of electricity needs to pass through so many layers of tissues to reach the heart, you need a lot more uh, voltage, or rather uh, output for the cardiac, so for the pacemaker to actually produce a beat. So we set it at something like 70 milliamperes, and we can go up to 130, and keep it above the 30 above the native rate. I'll not go into too much details of this. Stop me if I'm going too fast, or this is something that anyone has not understood. Malfunctions, the again, a numerous amount of malfunctions, both with temporary and permanent pacemakers. Not all of them are manifest on ECGs, but we're critical care physicians. We deal with patients who are in the ICU with cardiac monitors attached, receiving daily ECGs. So let's concentrate on things that can be actually picked up on ECGs. So the commonest ones, you have failure to sense, you have a failure to capture, and you have pacemaker mediated tachycardias. It's mainly failure to sense and failure to capture, which is usually the most commonest one. Pacemaker mediated tachycardia does occur. Then there is something called a runaway pacemaker, which is usually not seen with modern pacemakers. But if you have somebody who's come to you who has had a pacemaker inserted in the 90s, it can happen. But again, even if somebody has had a pacemaker inserted in the 90s, it would be replaced because batteries usually for permanent pacemakers last anywhere between 5 to 7 years. Indian pacemakers, because of some regulations, do last a little more longer. But be that as it may, unless somebody has used a old generation pacemaker, you don't really see runaway pacemakers anymore. That typically occurs because of battery failing, or old battery essentially, where the pacemaker has a runaway battery. It just goes crazy and still gives these sudden bursts of spikes of 200 or 300 beats. This is another example of undersensing. So basically, undersensing means the pacemaker does not sense the patient's heartbeat. And since the pacemaker does not sense the patient's heartbeat, it anyway puts out an impulse thinking there is no native heartbeat. Let me put out my own electrical activity. So when this happens, sometimes if the pacemaker spike, here you see there is a pacemaker spike, which is followed by a QRS, which is fine. But here you see the pacemaker spike actually falls on the T wave. So the T wave is actually it's the time for ventricular repolarization, and at that point in time, if an electrical impulse falls on the heart, it can actually trigger a ventricular tachycardia. If it falls somewhere closer uh, to the end of QRS, it may not really trigger a tachycardia because that's something called absolute ventricular refractory period. Beyond that, it can actually trigger a R1T phenomena and cause a ventricular tachycardia. This is actually fairly common, particularly in cardiac surgery units when they have used epicardial leads as a temporizing measure. We see it quite often even in transplant patients, cardiac transplant patients, and it's sometimes inevitable. Can be controlled with some amount of programming, or even switching over to a better pacemaker. So this is another example of undersensing, where there is a P, there is a QRS, everything, but still the pacemaker has its own mind, and it just keeps on giving spikes irrespective of what is happening. The second one that you see, again, the same thing. There is a P, Q, RS, everything, but the pacemaker is just not sensing the native heartbeat, and it's giving out its own electrical impulse. Now, the opposite can happen, what is called as oversensing, where the pacemaker senses a heartbeat even though the heart is not beating. Maybe the heart person is dead, and there is just some nurse standing or some doctor standing next to the patient and shaking the patient, or the BP cuff getting inflated, or any kind of vague activity which can be sensed as an actual heartbeat, and the ventricle and the pacemaker doesn't do anything. So it just, you can see these long pauses here there are two spikes, and there are no there's, even though there is no P waves anywhere, the pacemaker is not working at all. So this is called oversensing. Again, both these terminologies, oversensing and undersensing, is a little counterintuitive for those who are not very used to the terms. But here, sensing actually means the pacemaker sensing the patient's cardiac activity. If it is sensing too much, it'll just sense just about anything. So that is why when I said keep the sensitivity at half of what the sensing threshold you discover initially, and not one-fourth or one-third, or then if the pacemaker setting is set to too sensitive, then it'll pick up everything, your ventilator pushing in air and that, and every time you move the patient, or even the carotid beating or muscle twitches, everything can get just picked up, and the pacemaker will not fire an impulse at all. So that's over sensing. Under sensing is when the pacemaker thinks there is does not sense the patient's heartbeat, and thinks the patient's heart is not beating at all, and it fires. And so this was actually a case in circulation a while ago. Uh, very interesting. Here you see all these ones which are marked as star. You see the little spikes which are followed by QRS. They're behaving as uh, these are the triggers that you see, and then you see later some more triggers. Then you see a long pause. So it does look like intermittent undersensing, but then the important thing here is some T waves were before the QRS, some spikes are after the QRS, and only when the spikes were after the QRS, it is actually not sensing at all. So this basically means this somebody has configured this pacemaker accidentally as VVT. So instead of VVI, somebody has triggered it as VVT. So every time there is a ventricular activity, it kind of triggers a pulse, and and that's what is generating the QRS. And here, this refractory period here is what I mentioned earlier. This particular impulse has fallen on the absolute refractory period of the ventricle. Maybe this is a little complex, but it's fine if some of you do not follow it. Don't fret over it. If it falls on the absolute refractory period, and that's the reason it's not triggering. So in this particular case, they reconfigured it to VVI, and it was fine after that. Failure to capture. So failure to capture means the ventricle is sensing fine. The ventricle is also putting out an impulse, but the impulse that the pacer has put out has not caused a myocardial depolarization. So ventricle is sensing fine. It is pacing also fine. So the pulse generator is working okay. The sensing part of the lead is working okay. But somehow there is failure to capture. This can happen because if your output is set to too low, one. It can happen particularly in transcutaneous pacing. It can happen if there is a lead fracture. It can happen if there is infective endocarditis or any kind of gunk which is sitting on the lead at the end of it. It can happen if there is lead dislodgement. There are various scenarios where it can happen. As you can see, there are pacemaker spikes all over the place, but you don't see every pacemaker spike being followed by there's intermittent failure to capture here. And this can actually happen even with drugs toxicity. This particular case actually is a case of flecainide toxicity, where somebody was given too much flecainide accidentally and also had a temporary pacemaker in situ. Over a period of time, the heart stopped responding to the pacemaker, and this patient eventually suffered a cardiac arrest. So important to know, important thing to actually look for if any patient has come with any sort of toxin, and if that patient has a pacemaker, daily ECGs are a must, and maybe even more frequent ECGs are a must to see if there's been a failure to capture because of direct myocardial toxicity of the said toxin. Now, biventricular pacing, it's new kid in the block. So many of you might have already heard of this. This is called cardiac resynchronization therapy. So there is some delay in earlier when I spoke about the cardiac anatomy. First, the heart, the impulse comes to the right bundle branch, then it goes to the left bundle branch, then it travels across the a bundle of His and Purkinje system, both sides. So when there is a structural heart disease, or if there is a significant left ventricular disease, or if there is an LBBB, or if there is a bifascicular or trifascicular block coupled with an AV nodal block, the heart is not beating synchronously, right? The atria gives off an impulse, and RV needs to be sequentially or closely followed by the LV depolarization, which does not really happen in patients with poor heart. So these patients need what we call as a cardiac resynchronization therapy. I'll just go back to that earlier slide. So you have the standard RV lead, have the standard RA lead. In addition to that, you also push in another lead through the coronary sinus, and this is what paces the other ventricle, the left ventricle, so that the pacemaker is programmed to make the heart beat uh, in a synchronous fashion like it would typically be. There were a couple of trials. There was a block HF trial, and there is, I think, a PAVE trial, two randomized control trials, which did show a significant amount of. One was for atrial fibrillation, another one was for just for heart failure per se. It does have a significant amount of positive outcome benefit on mortality also on of these patients. So the indications, the class 1 indications, are patients who have an LVF of less than 35, and earlier they said only NYHA 3 and 4. These are ambulatory patients. It's not really useful in patients who are bedbound, and a white QRS with NYHA 2 to 4 on optimal medical therapy, or if you're anticipating a reliance on right ventricular frequent right ventricular pacing, or even in patients who have 35 to 40 percent ejection fraction, who are expected to require frequent ventricular pacing. So there are two types: the CRTD and CRTP. CRTP is just cardiac resynchronization therapy. It's just a biventricular pacing machine. There is no ICD, but a lot of these patients also have a need for a implantable defibrillator. ICD is implantable cardiac defibrillator. Many pacemakers have a defibrillator attached to it. So CRTD is more expensive. It's more bulky. So sometimes we'll have to figure out which one to put in. And if the QRS is less than 120, again there's a mistake here, sorry, and if the ejection fraction is more than 50%, and if the non-ambulatory congestive heart failure, that is patients who do not are not ambulatory or bedbound, these patients are also unlikely to benefit. Now, the newer exciting things which are happening, there are two devices, one by Medtronic and other by Abbott. There are a couple of more companies which are in queue. I think Boston Scientific FDA approval is almost through. There are a couple of more. I'm not sure if it's already through. There are a couple of more devices also which are waiting in line. There are some series of trials also which are running. So these leadless intracardiac pacing systems are the new thing in the market. Has been around for a few years. 2016 this was published in NEJM. At that point in time, there was no AV synchronous therapy. It was only VVI, that is a single chamber pacing and sensing algorithm which was there in these pacemakers. Now Medtronic has come up with a new device called a Medtronic AV device, where it is, to simplify things, it has a sort of a sensor at the proximal end of the cardiac pacemaker itself, and that actually uses some algorithms and an accelerometer and all that to kind of not accelerometer, sorry, it has an algorithm to basically sense the inflow of blood and opening of the tricuspid valve, and it's actually able to synchronize the right atrium and right ventricle. Now this device is out in the market. The FDA approval was based on physiological electrophysiological studies rather than because the predecessor already has enough evidence. But is it really an apple to apple comparison with the standard dual chamber pacemaker? It needs to be seen. It's not yet really known. So however, there were some limitations in the study which was conducted, and actually this is one of those things where the device might actually be more superior than it was kind of evident in the study, because the ones who were enrolled for the other control group, they were significantly more sicker patients, and they had more structural heart disease, etc., etc. And also, follow-up data was limited to 6 months and a select group of physicians. So it was a little limited, but looks like it may be actually better than what it was actually manifest in the study. More studies are awaited. Now, recently in Switzerland, somebody developed this new type of pacemaker. Now, many of you might remember that old Citizen automatic watch. You just walk and it gets recharged on its own using a basically automatic wristwatch technology. It uses an accelerometer and kind of recharges itself. So this kind of pacemaker can be sutured directly to the heart. This is still in prototype stage. It is not approved. It's probably, we're not sure if it will be approved, but looks exciting. If someone makes a smaller, bulkier, less bulkier version of it, very soon you may see these kind of pacemakers, which is just just do it once and then you're good to go for the rest of your life unless there is a complication. So energy harvesting is happening directly from the heart. So that's what is in store for the future. I'll stop here and take any questions.
Sanu, thank you for the talk. That was. And I just have one question. The older pacemakers. I just want everyone to be clear if you can give this answer in terms of there was processes of putting magnets and all those things uh, uh, to temporarily close it in ICUs and things. Can you just elaborate a little bit on that, please?
So the older ones, yeah, we used to. These were again, and I didn't touch upon that part of the classification. So there were pacemakers which were not programmable. So there were these pacemakers which are non-programmable, and in case of any sort of adverse effect with the older pacemakers, the only thing you could actually do is actually shut off the pacemaker altogether. And sometimes it could actually happen before this particularly happened when there was just say VOO mode in the past in certain pacemakers. So VOO mode means the ventricle just keeps getting paced no matter what. And also sometimes it so used to happen that when you're doing surgery, for example, uh, you use cauteries, and the electrocautery would actually interfere with the electrical circuit of the pacemaker. This used to happen if the pacemaker is set to VVI mode, and that used to cause havoc. Uh, and people would have to place a magnet to actually kind of stop the pacemaker, and in the interim insert another temporary pacemaker or something of that sort, or just medically manage. We don't do that any longer. There are still magnets which are basically programmers which you just keep on top of the chest. And most like I showed you earlier in one of the examples where accidentally somebody had set it to a VVT, it's very easy to program the modern pacemakers externally just by keeping a device on the chest. So we don't do it any longer. Yes, we do place a magnetic sort of device, but that's what we call as a pacemaker programming. What we routinely do, if anyone has worked in a cardiac unit, we call in patients for what we call as pacemaker interrogation regularly, and the device will check if everything is working fine, and if it's not working fine, it'll give spit out a report, and based on the report you can easily reprogram this, and it can be done bedside pretty easily these days. So we don't place a magnet to shut off the pacemaker any longer, but we do use a magnetic device to reprogram permanent pacemakers. Temporary pacemakers, there's no such thing. All the controls are externals.
So, do we have a time period when 1990s, 1995, before that, if a pacemaker was inserted, then you'll have to shut it off? Anything like that at all?
See, the thing is, it's 2023, so most pacemaker batteries would have exhausted in 5 to 7 years. Indian government had some regulations which said, we our pacemakers need to last longer. So I think Indian pacemakers will last for about 8 to 10 years. I don't know if that regulation is still there. So in general, you are unlikely to come across such a pacemaker uh, right now, unless somebody has shortchanged some patient and got something out of an old stock and put it, in which case it would be difficult for us to recognize these models. Actually, you would actually need an electrophysiologist or a trained cardiologist who has expertise in these devices for us to know. But like, practically, it's very unlikely that right now we'll come across a device which is put in, which was manufactured before 1990s. Yeah, Shashi, it's 9:30. I think you can.
One
No one
quick,
else. Yeah.
Okay.
I
Yeah.
just want to highlight the fact about, I mean, I remember actually removing pacemakers after people have died, uh, because if there is a cremation, then um, these pacemakers which have lithium batteries in it can potentially explode. So I don't seem to see that in our country at all. So I just wanted to highlight that part.
We do remove pace. I mean, I personally have removed pacemakers sometimes. Some of these pulse generators are actually taken off people who have just expired and then donated to other people. It actually, the leads can't be used, but the pulse generators actually can be reused, especially if it's like a fresh machine which has been put in. So in some centers, we do take out the pulse generators just with an intention of giving it to somebody else.
Hi team. If there are no further questions and if it's the end of the session, I want the CP team to stay back. Others can, you can end the session officially. You can end the recording, and after that, I'll give you a brief introduction about guest we have today.